Peripheral arterial occlusive disease, aorta and distal arteries. Peripheral arteries occlusive disease is a form of arteriosclerosis in which the peripheral arteries become blocked. Chronic occlusive arterial disease occurs much more frequently than does acute, which is the sudden and complete blocking of the vessel by the thrombus or embolus. Pathophysiology and etiology. Atherosclerosis obliterans, most commonly caused by atherosclerosis with contributing factors, may involve the following vessels in isolation or combination: aortoiliac system, femoral arteries, superficial femoral, profunda femoris, popliteal artery, trifurcating vessels, anterior tibial, posterior tibial and peroneal arteries, dorsalis pedis artery, pedal arch. Lesions tend to form at areas of bifurcation of the vessel. Pattern of disease differs in non-diabetics and diabetics. In non-diabetics, disease usually involves the macrocirculation, larger vessels, example aorta, iliac, femoral arteries, and is more common in isolated segments. Diabetes. Disease usually involves the microcirculation, smaller vessels, example popliteal, tibial, peroneal, and small vessels in the foot and digits, and occurs in more diffuse segments. Thromboangiitis obliterans, Buerger's disease, Buergers, Buergers, Buerger's disease. Inflammatory process of arterial wall which is followed by thrombosis also affects adjacent veins and nerves associated with heavy cigarette smoking. Clinical manifestations. Symptoms appear gradually and are specific to the area affected. Aortoiliac, mesenteric ischemia, pain after eating. Unintentional weight loss, renal insufficiency, poorly controlled hypertension, impotence, intermittent claudication. Femoral, popliteal and distal arteries. Intermittent claudication, rest pain associated with severe arterial ischemia, severe pain in feet aggravated by elevation of lower extremity. Pain is relieved by placing foot in dependent position. Dependent rubor, dusky purple color of extremity when in dependent position. Changes to pallor when elevated. Numbness, tingling of feet and toes. Trophic changes associated with tissue malnutrition, hair loss, thick toenails, thin shiny skin, cool temperature of extremity. Tissue loss, non-healing ulcers, which may develop wet or dry gangrene. Diagnostic evaluation, non-invasive. Vascular physical examination, ankle brachial index, comparison of systolic blood pressure in arm with that of ankle, may be done before and after exercise. Normally, the systolic pressure are equal. In presence of atherosclerotic disease, the pressure below an occluded area is less than the arm pressure. Doppler ultrasound, increased velocity of flow through a stenotic vessel or no flow with total occlusion. Segmental plethysmography, decreased pressure distal to region of occlusion. Invasive therapy, invasive diagnostic therapy, angiography to confirm occlusion. Management goals: re-establish blood flow to areas of critical ischemia, preserve the extremity, relieve pain associated with intermittent claudication or wrist pain. Conservative treatment includes modification of risk factors, walking, weight reduction, smoking cessation, and control of other conditions such as hypertension and diabetes mellitus. Pharmacologic treatment with antiplatelet agents or anticoagulants to improve blood flow by increasing erythrocyte flexibility and lowering blood viscosity. When conservative measures clearly are not enough, revascularization surgery, endarterectomy, arterial bypass grafting or a combination may be required. Endovascular procedures such as PTA may be used alone or with revascularization surgery for dilatation of localized non-calcified segments of narrowed arteries with or without intraluminal stenting. Amputation of affected extremity in cases of severe infection, gangrene, failed attempts at revascularization, or when revascularization is not considered a viable option. Complications: ulceration with slow healing, gangrene, sepsis, severe occlusion may necessitate limb or partial limb amputation. Thank you.